Hi, good morning. Sue Morris here from the New Brunswick Heart Center. I'm a clinical nurse educator, and today I wanted to talk to you about TAVI and electrical conduction disturbances that can happen in the postoperative period. I wanted to focus on transvenous pacing because many of the floors that I serve as an educator are experts in the field of epicardial pacing, and sometimes just enhancing your familiarity with different types of pacing will make you feel a little bit more comfortable in caring for these patients. So I'm just going to share my screen with you, and we'll just watch this presentation, and I have a few videos here to show you also. So TAVI, or TAVR, as some people call it, TAVI stands for transcatheter aortic valve implantation, and TAVR stands for transcatheter aortic valve replacement. And so when we think about the incidence of electrical disturbances following this procedure, you have to think about the aortic valve and its close proximity to the AV node. And so sometimes these conduction disturbances can be temporary due to edema, or they can actually be permanent. And some patients are at higher risk for that permanent electrical damage. So the incidence ranges from 4% all the way up to 31%. And that really depends on a number of conditions. And so the first condition we think about is the valve. And valve technology has really come a long way in the past 20 years. So we have improved on that component. An additional risk factor is pre-existing right bundle branch block. As you could imagine, you already have a pre-existing bundle branch block there, and now you may be putting additional strain or stress on the conduction system. Patients with atrial fibrillation have an increased incidence of conduction disturbances, and that is poorly understood. Not a lot of data about that in the literature, but definitely an increase in incidence in patients who have atrial fibrillation. Additionally, some other conduction abnormalities that are pre-existing that put the patient at risk are prolonged PR intervals, so first-degree heart block, and also patients who have a wide QRS, because obviously that is some type of a conduction abnormality that is pre-existing. The one thing that physicians discuss at length and really like to have a good understanding of the calcification that is happening around that aortic valve, and in particular, the distribution of calcium around the annulus of the valve. And so those are the main factors that increase the incidence of a patient having an electrical abnormality. So at the New Brunswick Heart Center, we use two types of valve. One is from Edwards and the other from Medtronic. And I just want to show you a video of each of these valves. So I will stop my share. And let's go to, first we'll look at the Edwards valve. You can see the valvuloplasty balloon going up, crossing over. Part is in the part is in the left ventricle, and other part is in the ascending aorta, and that opens the commissures of the valve leaflets. And now the device. And so that valvuloplasty in the balloon that the valve is on contribute to electrical conduction abnormalities because they put pressure on the electrical conduction system right about the level of the AV node. So during an actual insertion, the physician doesn't have the benefit of this beautiful animation. He or she is actually trying to place this valve under fluoroscopy. And you can see as my arrow is looking here at the ostium of the right and the left coronary arteries. So physicians have to be very diligent about placement, or that can cause occlusion of one of these coronary blood vessels. And this gives you a nice look at the valve. And so you see the aortic stenosis has been significantly minimized. And when you look down through into the left ventricle, you can see those lovely chordae tendineae. So here is the Medtronic valve.
Proprietary step deployment procedure for percutaneous aortic valve replacement. The Medtronic core valve system is uniquely designed to provide full valve function prior to complete deployment. Note, this animation is intended as a training supplement to the Medtronic core valve system training program and is not meant to replace the training program or the instruction of a core valve clinical specialist and proctor. Before we begin, let us go through and confirm proper setup and configuration of all instruments, and confirm that the patient anatomy is ready for the Medtronic core valve system. Make sure the patient's ACT level is greater than or equal to 250 seconds. Confirm that the super stiff guide wire is contoured to the inner cavity of the left ventricle. Confirm that the graduated pigtail catheter is positioned properly in the non-coronary cusp of the aortic root. Confirm that the camera is positioned in the ideal annular viewing plane as predetermined earlier in the procedure. Insert the Medtronic core valve system into the 18 French introducer and advance to the descending aorta while maintaining strict fluoroscopic surveillance of the extra stiff guide wire. When crossing the aortic arch, it is critical that the second operator controls the guide wire and prevents it from moving forward. Without proper management, the guide wire will move forward, possibly causing trauma to the left ventricle. Advance the catheter through the native valve. Note, during initial crossing of the valve, it is possible to have an unacceptable drop in systolic pressure. If systolic blood pressure drops below an acceptable level, withdraw the catheter into the ascending aorta and ask the anesthesiologist to increase blood pressure. Position the catheter tip into the LVOT and confirm proper camera angle by visual inspection of the radiopaque marker. If the marker appears as a straight line, proper camera angle is achieved. If it appears as an oval, consider repositioning the camera until orientation lines up with marker. Perform an angiogram. Confirm that the pigtail catheter is still within the non-coronary cusp of the aortic root. At this time, visually identify the distance between the base of the aortic root and inflow edge of the valve frame. Now, let us take a closer look at the crimped valve. Note the radiopaque contact points. Counting from the inflow edge of the frame, optimal placement of the valve is the shaded area between the first and second contact point implanted within the aortic annulus. After valve placement has been established, confirm proper guide wire pressure on the inner wall of the left ventricle cavity. After attaining optimal guide wire position, the second operator should slowly turn the micro knob and begin to deploy the valve. As the first part of the valve is unsheathed, it may move a short distance in either the antegrade or distal direction. If this occurs, Reposition the valve to the target implantation depth as deployment continues. Perform an angiogram. Valve can either be advanced or withdrawn as long as annular contact has not been made. As the inflow aspect of the valve starts to flare outwards, monitor valve position under fluoroscopy. Note, once annular contact is made, the frame cannot be safely advanced into a lower position. It can, however, be repositioned in the antegrade direction if the frame has been deployed less than or equal to 2/3 of its length. Careful assessment of frame position relative to the annulus is highly recommended for optimal implantation. After evaluation of valve position is achieved and adjusted at this stage, continue to deploy the 2/3 deployment. Note, during this stage, the blood pressure will drop. It is important not to stop deploying until blood pressure rises to normal parameters. Stop deployment and perform an angiogram. Target placement is represented by the highlighted line being lined up with the bottom of the aortic root. The shaded areas represent an acceptable implantation zone for the valve. If the valve is positioned low, carefully pull the catheter to reposition the valve. When satisfied with valve placement, observe the catheter position in the arch to identify the presence of tension in the system. If the position of the catheter is along the inner curvature of the aortic arch, this may indicate the presence of tension in the system, placing an antegrade force on valve. If tension is suspected, relieve the force on the valve by slightly pushing on the catheter just prior to valve release and retracting the guide wire until the distal tip of the delivery catheter centers inside the inflow aspect of the frame. Once tension has been released from the system as needed, turn the micronob until both loops disengage. Note, it is critical that you confirm that both loops have disengaged. Failure to do so may cause inadvertent movement of the valve from its intended position. Withdraw the catheter into the descending aorta. Close capsule and recover entire system.
And that is the two valves that we use at the New Brunswick Heart Center. So post-procedure temporary pacemakers, our physicians will use a transvenous pacing wire if the patient requires it. And so often the site of choice is the femoral vein. Some later implantations have occurred through the internal jugular site, but regardless, the wire that is used is pretty much the same. So there are two types of wires that can be used. One we refer to as a stiff wire, and the other is a floating balloon wire. And so physicians lately have decided that the balloon pacing wire is the preferred wire because of the incidence of cardiac tamponade that can happen with the stiffer wire. So I just want to show you a quick video of a temporary floating balloon pacemaker being inserted. And pardon the ad, we'll have to watch the quick.
And something surprising happens.
Today I'm going to teach.
Prior to inserting a temporary pacemaker, get the equipment, the temporary pacing catheter with the shrouded pins and introducer kit, and then the pacer itself, as well as the connecting cable. All right, so unwrapping the kit, we've got all this stuff in there, and of course this is going to be sterile and the physician's going to be doing it. And in the kit you have the pacing wire with the shrouded pins. and then drapes, and then the equipment here. The physician will be doing these steps, but so that we know what they are, first thing is to, again, this is sterilely, is to test the balloon. All right, here's a quick look at the catheter. So at the end of it, it's covered with this plastic sleeve to protect it and keep it in this nice curve. So when it's being inserted, it's easier to do. You'll notice that there's two electrodes here at the distal end. Distal is negative and the proximal end, proximal. And these are used for pacing and sensing. The distal one is going to touch the inside of the right ventricle, and that is what's going to send the impulse. You'll also notice on this there are little hash marks, so each one is 10 centimeters. There's 10, 20, 30, 40, 50, 60, and so on. When it's being inserted, you want to make sure to insert, or the physician make sure that they insert it past the 20 centimeter mark. At the other end of the cable, there is the stopcock for the syringe, and that's going to inflate the balloon, and the balloon has to be tested prior to inserting it into the patient. So we'll test that. And that works good. This syringe is set with a pre-volume, so you can't inject any more air in that. You wouldn't want to, so that you don't pop that balloon. Also, we have these two endpoints here, and there's a D for distal, negative, and there's a P for proximal, and that's positive. And we'll stick the shrouded pins that also come in the pack in those in a minute. The introducer part is here, and it has a sleeve over it as well. And then this is going to go into here to make insertion easier there. This needs to be flushed prior to inserting into the patient. After the physician has inserted the introducer into the patient, this part comes out. And prior to introducing the pacing catheter into the patient, this protective sleeve must go over here. This attaches on, and then the pacing catheter is going to be threaded through the end here. And remember, we had those markings. There's the 10 centimeter. It should go at least to the 20 centimeter mark. And you'll see that come out. There's the 20, and that is counting it when it gets to the catheter there. And then you see it coming out the end there. The physician may ask you to help with balloon inflation. So if that is the case, then go ahead and inflate the balloon, turn the stopcock so that it stays inflated, and then that can help with floating the catheter through the heart so it lands in the correct spot. Once you have capture on the EKG, or you think you're in the right spot, or you've seen that, go ahead and deflate the balloon. Then the pins that also came in the kit are going to be inserted into the ends here, and you have to push fairly hard in order to get those to stay in there. All right, now that the pins are in here, we're going to put it into the connecting cable, and you want to pay attention to the label. So D, distal, negative, is going to go into the negative hole there. Push it in and lock that in place, and then there's the positive P.
So for the nurses working on our cardiac surgery floor, we have epicardial leads, and placement of those in the negative and positive slots doesn't matter. But these transvenous wires, you can reverse the polarity if you're troubleshooting, but they are intended for the distal to be in the negative slot and the proximal or the positive to be in the positive spot. So pay attention to that. That should be connected for you when the patient arrives from the interventional radiology suite, but it's important that you observe that and document that distal is in the distal port and proximal is in the proximal port.
Positive or proximal. It's going to go in there and then tighten that down. Now we're going to power on the pacer.
So I'm going to stop here because we can use either pacemaker. So this is a pacemaker that the nurses on our 5B North floor have significant familiarity with. And I'm going to show you a quick video later of the single chamber pacing generator that the staff of 5A North have more familiarity with. So they can be used interchangeably because both devices will do VVI pacing, and that is what we will be doing for transvenous pacing, is VVI pacing only. So when we look at the nursing care that is required for these transvenous wires, you have to think about the differences between the patient with epicardial wires and the patient with transvenous wire. We ambulate our epicardial pacing patients routinely. However, temporary transvenous wire patients have to be on bed rest for two reasons. When the line is inserted, it is put in femorally, and that bending of the hip will cause some damage to the catheter itself. And ambulation may also cause a loss of contact with the endocardium and stop or lose capture. So bed rest, absolutely. Telemetry is required if the patient is on the floor, and if your patient is in your step-down unit, the 5B North, they will be on the hardwire monitor. If I was caring for this patient in the CCU step-down, I would have them on telemetry, but I would also have them on a bedside monitor. And we do not have portable monitors in our step down. So what I would do is take a defibrillator and I would take it into the patient's room. And the reason for that is when you have to manipulate or troubleshoot sensing or loss of capture, you as the nurse want to be able to see that change on the monitor. What are you causing the patient, what rhythm are you causing the patient to have when you manipulate the pacemaker? So I think it's very important that you have that in front of you. The patient, because he is on bed rest, should also be repositioned every 2 hours. And the head of the bed really shouldn't be much more than 10 to 15 degrees. But reverse Trendelenburg is really, will really be a game changer for the patient. They do not like to lay flat. I want you to think about your patient, and I want the patient condition to be the indication for whether the patient goes to the floor, the CCU, or the 5B step down. So a lot of patients with transvenous wires have been put into our 5B step down unit. I don't think that they all have to go into our step down unit, but if I had a patient who was asystolic, I would either want him in our step down unit or at least along the front wall that he is close to the nurse's station so that you can attend to that patient in a very quick manner. That's really the main differences in caring for a patient with a transvenous wire. We'll continue doing vitals just the same as we do for any post-op TAVI. You'll do an hourly check and document the insertion site and your pacemaker settings. If you are not comfortable with the generator that comes to the floor, so let's say a patient came to 5B North and they had the CCU generator. You can simply go get the generator that you are familiar with, input all of the same settings as the one that a patient has arrived with, and then you can simply change your transfer cable. That's it. You set the settings exactly the same. You take the transfer cable from one device and put it into the other. Ensure that if you are using the dual chamber pacing generator, that you are putting the transfer cable in the ventricular slot, because with transvenous pacing in our facility, we just do VVI pacing. So I'm just going to show you a video of a couple of different devices, or the two different devices that we have at the New Brunswick Heart Center.
Section, we will demonstrate how to perform a sensing threshold. But first, let's review the functionality of the dials and buttons on the 53401 single-chamber temporary pacemaker.
This is a lovely.
The on-off button is located here. This is the lock-unlock button. Pacing rate is adjusted using this dial. This is the dial to adjust the pacing output in milliamps. This is the dial to adjust sensitivity in millivolts. These are the controls for rapid atrial pacing. This is the battery indicator. This is the lock indicator. This is the green light, which indicates pacing when flashing. This is the blue light, which indicates sensing when flashing. First, we'll review the basics of sensing. For the pacemaker to pace at the appropriate time, it needs to sense the patient's intrinsic rhythm adequately. Sensing is like a fence. The higher the number, the less sensitive. The lower the number, the more sensitive it is. When a fence is set low, more is seen on the other side of the fence. The higher the fence, the less is seen. This is true for sensing. With lower numbers, more will be seen. With higher numbers, less is sensed. Appropriate sensing results in every heartbeat being properly sensed. This means that when the lead or wire is located in the atrium, all P waves are sensed, and when the lead or wire is located in the ventricle, all R waves are sensed.
So our lead will be placed in the ventricle, so the device will be looking to sense or see the QRS, the R wave. We do not do AAI pacing in this facility through transvenous. The only time that you would do AAI pacing is either a permanent pacemaker or a post-op cardiac surgery patient who has an epicardial wire. But when we use transvenous, we do RV pacing, and that allows us to do VVI and VOO pacing only. But as we have discussed in all of our education, VOO usually means, uh-oh, why are we not sensing? And so VVI is the preferred setting on our device.
It also means nothing extra is sensed, such as a T wave, which would be interpreted as a heartbeat. To perform the sensing threshold test, first, turn on the temporary pacemaker without connecting it to the patient lead system. Ensure the patient is connected to an ECG you can monitor during the testing. When the temporary pacemaker is initially turned on, it will begin sensing and pacing in AAI or VVI mode with nominal values of a rate of 80 ppm, output of 10 milliamps, and sensitivity at 2 millivolts. In this example, we will determine the ventricular sensing threshold in a patient who has an underlying rhythm of 50 beats per minute. The temporary pacing lead or wires are in the ventricle. Recall the definition of the sensing threshold is the least sensitive setting at which the pacemaker can detect a heartbeat. The sensitivity setting allows you to control the pacing mode between synchronous or demand pacing and asynchronous pacing, also referred to as AOO, VOO. Notice the range on the sensitivity dial goes from the most sensitive setting of 0.4 millivolts to a setting labeled async. When set to async, the sensitivity is set to a value so high that no underlying intrinsic signal can be detected. Therefore, to pace asynchronously, set the sensitivity dial to async. To pace VVI or AAI, the sensitivity setting must be set so the device detects the underlying rhythm. Set the rate to at least 10 ppm under the patient's intrinsic rate. So in this example, we will set the rate to 40 ppm. To reduce the risk of competitive pacing, decrease the output to the minimum value of 0.1 milliamp. Plug the pacing cable into the socket located on the connector block on top of the temporary pacemaker. Verify that the cable end clicks when it is inserted into the temporary pacemaker connection. The audible click signifies that the plug is completely inserted into the receptacle. Note the sense indicator is flashing, which means the device is detecting the R wave. In other words, the R wave is at least 2 millivolts. Monitor the patient's ECG to ensure the sense indicator matches the device lights. Slowly turn the sensitivity dial clockwise, which increases the millivolt value, until the sense indicator stops flashing. The pace indicator flashes continuously, but capture is not likely because the output value is set to the minimum. Next, increase the sensitivity by slowly turning the dial counterclockwise, which decreases the millivolt value until the sense indicator starts flashing. The pace indicator then stops flashing.
Now, our process actually tells you to set the fence at the highest numeric value and work your way down. So there are two ways of testing the sensing threshold. You can start very low and then increase your numeric value until you lose that sense light, so you don't see it anymore. Or the other way is the way that we practice at the New Brunswick Heart Center is we set the fence way up here at 20 millivolts. The sense light is not likely to come on, and we lower that value until we see the sense light come on. And then we look and say, if it came on at 10 millivolts, then we will lower that sensitivity. I shouldn't say lower, we will lower that numeric value and set it to 5, which increases our sensitivity. So that is the device that is used on 5A North. And I'm not going to review the device that we use on 5B because the staff of 5B are very familiar with that. And so that brings us to the end of our discussion about transvenous pacing. When we look at this device, so here is my sheath or introducer. I will have an intravenous infusing over here, just maybe saline or dextrose at a minimum of 20 mils. And my stopcock will be in the open position, and the air will be removed from the syringe. So there will be no air in the balloon when it is in the patient. The air is only put in to assist with insertion. So it kind of acts like a sail. The blood will get behind that balloon and float it into the right ventricle. So please do not be shy. If you have any comments or questions, you all have my cell phone number, and thank you for your attention.